Ladies and gentlemen, thank you very much for joining us tonight. My name is Glenn Wallace and I'm CEO of GP Supervisors Australia. So thank you for giving us an hour of your time to run through the voluntary assisted dying. We've got Dr Greg Mewett with us tonight, who will be presenting on tonight's session, but he is going to introduce himself as the expert on that particular topic. Rightio, so as is customary for the GPSA webinars, we'd like to acknowledge the traditional owners of the land on which this meeting is taking place and pay respects to their elders past and present and their families.
Well, thank you very much, Glenn. Good evening, everyone. And my aim tonight really is to give everyone a particular overview of the voluntary assisted dying legislation as it stands in Victoria. Of course, WA have recently passed the legislation, but will not come into effect until an implementation period, as was done in this state. Most of you will probably have read my bio, so I won't bore you with that. I used to be a GP in Bendigo for 22 years, very involved in palliative care, and I've been a palliative care physician now for the past 13 odd years. I was asked to be on the voluntary assisted dying implementation task force, and that was an 18-month period leading up to and just beyond the legislation coming into effect. I just wanted to remind people really of the overall, I guess, idea of comprehensive care at the end of life, that we start really at one end of the spectrum with wellness, develop illness. We have various responses to those illnesses, often curative and restorative, but also sometimes palliative. With advanced, progressive and incurable illnesses, palliative care becomes more involved, and perhaps curative and restorative care becomes less involved as time goes on. And then it becomes obvious that end-of-life phase has arrived and end-of-life care becomes even more important. Voluntary assisted dying is a small part of end-of-life care leading up to death, and of course bereavement occurs beyond the death regardless of the cause or the manner of death. So just a schematic way of thinking of this as a spectrum of care. So I will be skipping over a number of slides tonight because there's quite a lot of detail in this, and we want to try and get the juicy bits and also to answer some of the questions, some of which have already been typed in advance. So the Voluntary Assisted Dying Act in Victoria was passed by the Victorian Parliament in November 2017 and commenced operation on the 19th of June this year. This followed at least 2 years of consultation and development, and certainly seems to reflect, or they wanted to reflect, a balance between giving people choices at the end of life and ensuring that there's community safety and that the legislation would not be abused. The policy, of course, is now settled and the focus has been on the implementation of the Act. So no further arguments, well, you can argue as much as you like about the pros and cons of voluntary assisted dying. We now have to get on and deal with the fact that it is now a legal option for some people at the end of life, and how we deal with that is important. So once again, a lot of information, but just to say that the Act itself sets out the legal requirements for voluntary assisted dying, but like any other clinical intervention, that voluntary assisted dying being one of them, there have to be considerations other than just the legal aspects, and that was the reason for the implementation task force that I was involved in, was to actually put the Act into practice and to see that it was actually was fit for purpose in practicalities. And of course, that's going to be an evolving thing with the new legislation. The Act also establishes the Voluntary Assisted Dying Review Board. It's not just a faceless board of people. There are some eminent medico-legal, pharmacy and representatives from the community on this board, which are tasked with reviewing, monitoring the overall rolling out of the Act and its ongoing processes. It reports to the government again on around the 19th of February this year. So this will be the first report that will give any meaningful statistics and figures about how voluntary assisted dying is being accessed in this state. The important thing, I think, to remember when we're talking about voluntary assisted dying is that, and I think it's very important to impress upon yourselves and also your trainees, is that voluntary assisted dying doesn't give people any inalienable right to end their life or to have assistance with dying. But what it does do under the Act is it gives people the right to be asked to be assessed for eligibility. So they can ask for assessment they may or may not be eligible under the fairly strict eligibility criteria, but they don't have any right to come in and demand voluntary assisted dying. The other important part of this Act, which has been controversial to some extent, is that health professionals are unable to initiate any discussion about or suggest voluntary assisted dying as an option in the course of providing health or professional care services. I guess what that means in its crude terms, if you're looking after a patient, you're talking about end-of-life issues, you are not able to raise the option of their voluntary assisted dying. This could be construed as unprofessional conduct under the Act. It is not a fine, but unprofessional conduct. This would, of course, require someone to perhaps vexatiously report you, but it's really a very important part of the Act in this state, which was required to act as a safeguard so that people wouldn't lead people down the path. For example, you know, someone's got terrible pain and you're throwing up your arms in the air, well, look, you know, I can't do any more for you if you thought about voluntary assisted dying. I mean, that's perhaps an extreme example, but it is one thing that was important for the legislators to actually get this legislation through the Parliament. Of course, it's not part of the WA Act and it's not part of other legislations in other jurisdictions around the world, and it will be debated and discussed further and maybe up for discussion down the track when the government is next set to review this legislation in 4.5 years' time. But where that is as it is, and people are not able to make that suggestion off the cuff until the patient actually raises it, and we'll come back to that a bit later. The other important thing to understand is that no one else can make a request for voluntary assisted dying on that person's behalf. It has to come from the person themselves. Also, voluntary assisted dying cannot be requested in an advanced care plan or directive, so that people can't think ahead and say, well, look, when I get to a certain stage of my dementia, please bump me off. That's not possible. People have to have decision-making capacity right up until the time of the voluntary assisted dying. Also, people often say, well, look, I'm the medical treatment decision maker, or previously called the medical power of attorney. What rights do I have? Well, basically, they don't come into play because patients have to have that full decision-making capacity. And of course, substitute decision makers only really come into effect when a patient no longer has that decision-making capacity. So being a decision maker does not have any particular impact other than the fact that you might be a support person for that patient. The other thing is that a patient with a mental illness or disability alone is not eligible for voluntary assisted dying. They would need to have one of the other criteria, which we'll come to in a moment. Patients must be encouraged to discuss their decision with the people close to them, including their family, and also, of course, the health professionals involved in their care. Specialist palliative care services must be discussed with the patient. That's very well clearly set out in the Act that people must raise those options for patients. If communication is difficult with this patient for whatever reason, then of course special resources such as speech pathology, Auslan interpreters, accredited language interpreters are important. And of course, in the actual assessment, formal assessment phases, use of a family member as interpreter is prohibited for fairly obvious reasons, as things can become lost in translation when someone close to the person is translating. So formally accredited translators are important. And of course, patients must be aware, and we make patients aware at any step of the way, that they can withdraw from the process of voluntary assisted dying at any time, right up until the time of actually taking their medication, if that's the situation. So patients need to have that understanding. So most people would know that you have to be over 18 years of age, you have to be an Australian citizen or permanent resident of Australia. You have to ordinarily have been a resident in Victoria for at least 12 months at the time of making your first request, and you must have decision-making capacity in relation to voluntary assisted dying. You must also have a medical condition which is incurable, advanced, progressive, and will cause death, and is expected to cause death within weeks or months not exceeding 6 months, or in the case of patients with neurodegenerative disorders, classically motor neurone disease, 12 months for those people. They are eligible if they are expected to have that sort of prognosis within 12 months. And of course, the other thing, which is the intangible and is this very subjective, is the idea that the suffering cannot be relieved in a manner that the person considers tolerable. I think getting down to what are the possible roles of the GP in voluntary assisted dying, I mean, there are a number of possible roles. from go to woe, really. I mean, I think the important thing about general practice, of course, and it hardly needs me to tell this audience, is that a patient with a progressive advanced illness of any description, whether it be COPD, cancer or heart failure, these patients should have advanced care planning discussions with their GP, and you'll often get in those advanced care planning discussions some prior warning about a patient's attitude towards things like voluntary assisted dying, things like resuscitation, things like being on a ventilator, etc., etc. Now that's really important. I think the GPs, regardless of views about voluntary assisted dying, need to be able to respond to a patient or family's inquiries about VAD and their request for information about this now that it is a legal option in this state. And I think we also need to be better at responding to patients' requests to hasten or bring about death. Patients often make very vague statements about, you know, wanting it all over and wanting to be out of here, but may not be actually making a request about voluntary assisted dying, and that needs to be explored with the patient fully and discussing the full range of end-of-life care options. Clearly, GPs can be a conscientious objector. There is nothing in the legislation that will enforce a GP to do anything regarding voluntary assisted dying. It's a very generous conscientious objection clauses, and you don't even need to have to refer patients on. I mean, obviously, codes of practice in our profession would, I hope, behove us to at least point patients in the right direction for further information, whether it be the website, the DHHS Voluntary Assisted Dying website, which has a host of information on it, both for the public and also for health professionals. Or we may even want to refer them to one of the voluntary assisted dying care coordinators, which I'll talk about in a little while. GPs, of course, are quite within their rights to set their own ethical levels of understanding about this. They may take a neutral stance, as I know some GPs do. They support the patient's decision. They provide all the usual care, including palliative care, but they don't choose to have either done the training or be supportive of actually going through the process of VAD. So that's another option. We direct patients to information sources, as I've said, maybe refer to another doctor or for VAD assessment, or the GP may in fact indeed agree to be a coordinating medical practitioner, what I call, as I call myself, not a conscientious objector, but a conscientious provider of voluntary assisted dying. And of course, there are some requirements for GPs who wish to become trained in voluntary assisted dying assessment, and you must be VR'd, you must complete the mandatory online training, which is available by that website. So I think the other thing is that people often ask me, and you know, trainees and registrars will say, well, what justifies, what qualifies as a patient asking me about voluntary assisted dying, given that I'm not myself allowed to raise this as one of the end-of-life options? So I've already hinted at this, that if you've been around dying patients long enough, these are the sort of statements, I won't read them all out, I think you can see them there clearly, but just some examples would be, you know, I've had enough, look, you know, I just want to get out, I just want to die. You've got to be able to hurry this up. You know, they use the veterinary analogies of the green dream or the dog being put down. You know, these are very vague statements that I would say need a fair amount of clarification, because there's no doubt that these patients aren't always asking about voluntary assisted dying. They are actually asking about further support, what can be done. They may be about to ask about voluntary assisted dying, but certainly these are sort of vague things that I wouldn't jump in and say, oh, you mean voluntary assisted dying? I think we need to clarify that in more detail. And the way I respond to that is I always ask a question, answer a question with a question. As someone said, why? And I said, well, why not? Why are you asking me this now? Can you tell me more about what you're feeling and how you're feeling at the moment? How are things going for you? What exactly are you asking? Sounds like things are pretty bad for you. Let's talk about this a bit more. And often by that, you can lead patients and then they will take you further. They may not ever mention voluntary assisted dying. They might say, well, look, this pain is unbearable. I'm too much of a burden on my family. And it can open up a whole range of areas for discussion and further support that the patient may require, either at a physical, psychological, or social level, or spiritual level even. I think things like these requests are really more specific, and they may only require a little bit of clarification, if any. So if a patient actually says, you know, I've heard about the new euthanasia law, how do I go about getting assistance to die? I think that's a fairly clear request for them to have the discussion about voluntary assisted dying. How do I get that pill they say you can get to end it all if it's too much? These sort of statements, I think, you think I'd qualify to get assisted dying under this new law? These are things that a patient is really saying, you know, I want to discuss this. They may not use explicitly the term voluntary assisted dying. And of course, voluntary assisted dying covers both physician-assisted dying with the patient self-administering and a physician-administered voluntary assisted dying, which some people call voluntary euthanasia. But voluntary assisted dying is the blanket term for that. It's not just euthanasia. Euthanasia will be the minority of these cases in it, and it'll be voluntary, of course. So patients may not use the terminology, and you don't have to. They don't have to say that. They may just need to be fairly clear about that they're actually talking about this new legislation. So how do you respond? And what do GPs and how do we teach our trainees to respond? Well, I guess your response is going to depend a little bit on the level of comfort about discussing the issue. And for a lot of people, it's not a comfortable issue. In fact, for a lot of people, discussing end-of-life care and end-of-life discussions anyway is not comfortable. But certainly, the more comfort you have in discussing death and dying and end-of-life options and palliative care, the more likely you are to become comfortable discussing this issue, because after all, it is now just another legal option for some, a minority of patients, who will choose to take this option near the end of life. It'll also depend a little bit on your working knowledge of the Act, and that's one of the reasons of tonight's webinar, and what implications that has for your practice. It'll depend a little bit on your moral and ethical stance on assisted dying, whether you're a conscientious objector, or whether you're ambivalent, or whether you're a conscientious wish to be a conscientious provider, and also whether you're prepared to work with your patient to explore all of the end-of-life options, including voluntary assisted dying. I guess it's important when we're talking of patients, we need to have an understanding of the patient's medical condition, including their prognosis. And, you know, I'm not always an expert in prognosis of patients. So sometimes we need to have discussions with their specialist. If it's an oncology patient, with their oncologist. If it's a patient with nasty heart disease, with the cardiologist, to get an idea of prognosis before we even get to step one of taking them down the voluntary assisted dying path. And also it depends on whether you're willing to be a patient's coordinating medical practitioner, which does take time and a degree of effort. I think it's important that we should start at least by letting patient know early on if you have a conscientious objection. But whilst not closing off the conversation, saying, look, that's not something that I wish to be involved in or that I agree with, but I think there's more information available and I can give you some information about where to go and get that further information if you like. Obviously, I like to talk to patients about what's really led to their request in the first place. Further discussion about their suffering and options available to address it, regardless of whether they're going down, they even wish to continue down the voluntary assisted dying pathway, they still need to have their suffering and other options addressed as good palliative care would dictate, I think. I think we direct a patient and also yourself, I'd suggest, to the website, the DHS Department of Health and Human Services website in Victoria, voluntary assisted dying, huge amount of information, and then maybe agree to meet the patient back when you've both had a chance to do a bit of reading up on the issue and have a further discussion. You might suggest, if the patient's adamant, that they contact the VAD care navigator. There are two full-time care navigators based at Peter MacCallum, not just for cancer patients, but they're based there. And now each regional area of Victoria has a part-time VAD care navigator available as well. And these people will be available as a link really between patients and the system for information, and maybe even direction towards a doctor who is prepared to be a consulting or a coordinating medical practitioner. I think it's important that we are able to have enough information at some stage to at least inform the patient about the nuts and bolts of the Act, which I'm trying to do tonight, the eligibility criteria, because it may be at first step, you can say, look, I don't think you're going to qualify. These are the eligibility criteria. You do not seem to meet that, but we can get further opinion about that if you like, without even starting off down the VAD formal pathway. You need to talk to patients about the steps that are involved, the likely timeline involved, the absolute minimum, and the stars would have to align incredibly well for 10 days to occur. That's the absolute minimum under the Act. more like a 2 to 3 weeks process. This is not an emergency issue, and it takes time for the process to occur. And also patients have to understand, of course, the outcome of the voluntary assisted dying is certain death. I think it's important to be honest if we're uncertain, and also I think to teach trainees that if patients, patients can test you out a bit and take you unawares. And I think, look, I'm not sure about all the laws, but look, I think we can find out and discuss it again. You may also say that they might not qualify under the law, but let's have another look at it. So buy yourself a bit of time. It's unlikely to be urgent. And look, we need to get further advice from your specialist about your prognosis, because a lot of this stuff does hang on the prognosis, clearly. If you refuse a request for voluntary assisted dying, you must inform the patient within 7 days and provide reasons for your decision. The 3 reasons really are that you have a conscientious objection to the... Now, that's a conscientious, ethical, moral, religious objection, not just because you can't be bothered doing the training. You may choose not to do the training because it's too time-consuming, you don't get recompense for that, and you don't wish to go down that path, just as like some people don't want to become methadone prescribers, some people don't wish to be AU486 prescribers, don't want to do the training. You don't have to. But you need to tell patients early on that that's in fact the case, or that you're not qualified under the Act because you haven't been vocationally registered, whatever, or that you will not be available if you're going away for 6 months on long-term sabbatical leave. Well, then you're not going to be around. So you can tell the patients fairly quickly if you're not going to be involved. But look, I think as the guidelines say, the discussion needs to be managed sensitively with respect to the patient's choice, not just sort of, oh, don't be ridiculous, go and see someone else. I think we need to be very sensitive about that because some people will need to have a lot more discussion. I think I'll briefly go through what requirements the medical practitioners. There are 2 medical practitioners that need to be involved in the assessment and approval process. Each of them must hold either a fellowship of a specialist medical college or be vocationally registered as a GP. And they must have completed the approved assessment training online. The average time for the training is 6 to 8 hours. You can do it in modules. I did it over a weekend, and a number of people that I've discussed it with have taken either a bit shorter or a bit longer. You have to pass the little test at the end, and then you have approval to register for the portal, which allows you to do all the assessment and paperwork online. Yes, it takes time. Yes, you need to be motivated. I had just as an example, I had one of my old medical colleagues, so that dates her and me. They ring me to say she's just done the training. It took her about 8 hours. She's so pleased she did it. It's given her a lot of insight because she's had 1 or 2 patients, particularly close, long-standing patients, that she didn't want to abandon and wanted to help. And she found the process very, very a very fruitful and worthwhile thing to do, despite its time constraints, time-consuming aspects. So either the coordinating doctor or the consulting medical practitioner must have practiced for at least 5 years, so either one of them. And they 5 years post-fellowship or post-VR. And either of them must have relevant expertise and experience in the disease, illness or condition expected to cause the death. So there are requirements that are well set out, and these things are well explained on the website as well, but that's just some details of the type of medical practitioners that can then do the training. So the go-to website really is the Department of Health and Human Services, Voluntary Assisted Dying, and there's health practitioner information. There's a lot of information supporting patients who are not eligible to access. We've got some training videos there, and obviously a lot of information regarding the Voluntary Assisted Dying Care Navigators, the statewide service. So there's some important numbers there which can be just got, but really just getting onto the VAD. I always just Google DHHS VAD and it comes up as the first website that comes up on that search engine. Just very quickly to go through that, patients must make 3 separate requests. They make a first request verbally to their medical practitioner. The practitioner could decide to become the coordinating practitioner even prior to doing the training. So you can take a patient's first request, document that in the patient's medical record, and then you can do the training. you must have done the training before the patient comes back for their first assessment. They have their first assessment. If found to be eligible, then they should be referred to a consulting medical practitioner. If the consulting medical practitioner finds them eligible, then they can make a written declaration, witnessed, and then a final request. The final request has to be at least 9 days after they make their first request, although some dispensation can be given to patients who are likely to die within that time. But generally speaking, at least 9 days after the day on which they made their first request. So there's a bit of time, and it usually takes longer than that, as I said earlier, to go through the process to get that those assessments done. So I'm not going to go through all the processes because this is great detail, which really is very well covered in the online training. And for doctors who are not taking patients through this as a coordinating or consulting doctor, then they probably don't need to know this in great detail tonight. I think it's important to understand that a patient who is found eligible by both the coordinating medical practitioner and the consulting medical practitioner, the coordinating doctor is then able to apply for a VAD permit. And there are two types of permit, very important to describe because this can be quite confusing. The default position in this state, and it will be in the, I presume in WA as well, I think, is that most patients will be expected to self-administer the VAD medication. So if a patient's able to swallow, ingest and absorb, and it's not 100 mils of liquid, they've actually reduced that to about 30 to 50 mils of fluid because the VAD medication powder is made up into that amount of fluid, and they have to drink that over 3 or 4 minutes. Be able to ingest it, in other words, get it down and absorb it. A patient has to be able to take it themselves unassisted, but they can have assistance in preparing or mixing up the liquid. The coordinating medical practitioner prescribes the medication. Statewide pharmacy delivers it to the patient in a locked box and goes through in great detail about the storage, preparation, etc., and the implications of the medication, which the coordinating doctor will have already done to some extent. And there'll be pre-medications in the kit that are taken about an hour before, so some antiemetics, anxiolytics if necessary, and the liquid for dissolving the VAD. The taste disguising liquid has been left out now. It hasn't been shown to work. So the liquid for dissolving, it doesn't taste all that great, but that hasn't been a problem so far with patients that we know who have taken it. Any leftover or unused amounts for the actual medication, not the pre-medications, have to be returned to the pharmacy, and the pharmacy will arrange to collect that from the contact person who is appointed by the patient to be needing to return any unused, or if the patient indeed dies prior to without having taken the medication, then that medication has to be returned to the pharmacy, which of course the central pharmacy is at the Alfred Hospital in Melbourne. The other type of permit, of course, that's available that is going to be less likely, but it has been accessed, to my knowledge, is that if a patient is physically unable to swallow, ingest and absorb the VAD oral medication, then a doctor prescribes and the pharmacy delivers to the doctor, the coordinating medical practitioner, the intravenous. It's a different medication to the oral medication generally, and it can be given by IV injection. The only exception to that, where it gets a little bit tricky, is if a patient, for example, let's say motor neuron disease patient, happens to have a PEG feed in situ, then the oral VAD medication can be given down the PEG tube by the doctor. Of course, if a patient is able to self-administer, they will do that, but if they're unable to self-administer because of their motor neuron disease, it can be given down by the doctor, but they will have to have a practitioner administration permit. The most common situation will be where a patient is unable to swallow, for example, with a nasty upper GI cancer, or absorb it, then the IV injection of different medication can be given by the coordinating medical practitioner, and it has to be witnessed, whereas the self-administration does not have to be witnessed. And a patient must have decision-making capacity right up to the point of practitioner administration and be given the option of not proceeding, as I mentioned earlier. So I think that's further about the permits. Once the permit is issued, there's no expiry date. The medication can be prescribed when and if the patient chooses. So just because the script has been written, it's the patient that chooses when the medication is delivered. They contact the pharmacy. And the patient cannot choose between those two types of permits. The patient cannot say to me, look, I think I'd rather have the intravenous, thank you, doctor, it'll be quicker. They can't choose. It's a choice that has to be based on the patient's actually medical situation. So these are functional, these are practical aspects of the legislation, which it all sounds very functional, but it occurs in a much more nuanced and, of course, sometimes emotional way than that. So the statewide pharmacy at the Alfred Hospital acquires the medication, packs it into kits, secures it, and accepts the prescription and liaises with the coordinating doctor and the patient to dispense it and give a lot of information about that. And they notify the review board within 7 days of actually dispensing the medication to the patient. They also dispose of any unused medication. The other thing that's often asked about, and excuse me if I just have some water, about the death certification after a patient dies after voluntary assisted dying. This is normal. Medical certificate needs to be done, as is legal in this state. You must complete a death certificate within 48 hours of the death of the patient by a registered medical practitioner who, as the law states, was either responsible for the person's medical care for death or who has examined the body after death and reasonably believes and knows that the deceased was the subject of a VAD permit. So some of you may have, and I've certainly done a couple now. The death certificate has a tick box that says, do you reasonably believe that the patient was subject to a VAD permit? If you tick yes, a further drop-down box occurs, which gives you the options of saying the patient died without taking the medication, the patient died after taking their self-administering, or the patient died by practitioner administration, and that is part of the death certificate. Now, the death certificate does not get issued to the family as a public document, does not mention voluntary assisted dying. The manner of death is the voluntary assisted dying substance taking. The cause of death is given as the underlying cause that led to the patient being eligible for voluntary assisted dying, whether that be the cancer or motor neuron disease or whatever disease it was. The death certificate doesn't have to be completed by the coordinating medical practitioner, it can be done by any GP or any even resident at the hospital if that was the case, as long as they understand about the drop-down box that they have to attest to. The other thing that has to happen is that that the same sort of details, the coroner's office has to be notified. So a phone call to the coroner's admissions and inquiries office, just to say that you wish to notify the patient, notify the office of a voluntary assisted dying death. It's not a reportable or reviewable death under the Coroner's Act. The police do not need to be involved. The coroner, it was just an extra layer of data collection that was imposed upon the legislation during the amendment phase. So it doesn't need to phase anyone. I've done that a few times now. You just ring up, they take a few details. That's the end of that. So the death certification is not in any way more onerous. One of the things that's important, I think, with any of us involved in voluntary assisted dying, and what we're certainly attempting to do now statewide and also in our hospital, our health service in Ballarat, is that we need good peer support. People involved in this, whether it be doctors, nurses, particularly in hospitals or in the community, we need to have peer support set up. We need to actively seek that peer support. We need to pre-brief and debrief about our involvement with these cases. We've set up a community of practice that's statewide, and I'll mention that in a moment. That is an opportunity to share and learn and support, improve our skills, and self-care is very important in these issues, as it is in any end-of-life care practice, but in this particular one, it can be quite confronting to some people as well. The community of practice that we've set up has actually been set up by the it's actually administered by the Western Victoria Primary Health Network, set up under the Victorian and Tasmanian PHN Alliance, and doctors who have done the online VAD training can email the West Vic community at westvic.pa.gov.au as you see there, and join that community of practice where there's some interesting discussion about sharing information, sharing ideas, sharing experience, and supporting each other in that. And also the Voluntary Assisted Dying Care Coordinators have set up a community of practice with themselves and also other nursing, for example, community nursing staff or hospital nursing staff. I just want to finish off to some extent by talking about the case of Jenny, and then we might be able to get to some of your questions, because once again, the talk can be pretty dry when I've given you the bones of the outline of the Act. But I think to put some flesh on the bones, we need to really look at how a typical case or a case may work. And of course, this is a case that's it's a hybrid of a number of cases, but I'd just like to take you through this so that you may have some understanding of how this might work in practice for those of you who have not been involved. So I present here a case of Jenny, a fictional 67-year-old woman who's always lived in Melbourne, married to her husband John for 42 years, 3 adult children, 2 grandkids. She's worked as a legal secretary for many years and has always been fit, active, independent, no history of mental illness. Jenny has undergone surgery and quite aggressive chemo for colon cancer, and further tests now reveal that her cancer has spread to her liver and right lung, so she's got significant metastatic disease. Jenny's oncologist now explains to her that after they've had a detailed discussion about her prognosis, that she's likely to die within the next few months, that further chemotherapy or targeted immunotherapy is very unlikely to be effective. She's experiencing a lot of unstable pain and nausea, and everyday activities for Jenny are starting to be increasingly difficult. So palliative care is obviously involved in the community and it provides some relief. She's regularly experiencing breakthrough pain though, and hates the side effects that her medication causes. A range of medication regimens have been tried by the palliative care team, including in conjunction with the palliative care physician, but Jenny continues to experience symptoms. She doesn't wish to have extremely strong medication or bigger doses because she knows that will increase drowsiness. She wants to make the most of her time with her family, grandchildren, and be as active as possible as what she's been used to under difficult circumstances though. She tells her GP one day that she's actually beginning to think seriously about voluntary assisted dying. And, she's read about this and she's really seriously thinking about it. After asking about voluntary assisted dying, both Jenny and John make a follow-up appointment with the GP a week later. And at that appointment, Jenny says that she is in increasing pain, discomfort, distressed by her poor mobility and dependence on others, and really is formally requesting assistance to be assessed for voluntary assisted dying. So on receiving that request, the GP agrees to be her coordinating medical practitioner and support her through the process. Now, as I said before, the GP may not have done the online training, but because the GP, he or she is very devoted to caring for Jenny, decides that yes, she will do the training online and performs a few days later, having successfully done the online training, does an eligibility assessment, finds that Jenny is eligible under all the criteria, in other words, her residential demographic and also her prognostic and capacity criteria are all been met, is referred to a consulting assessment, which fortunately is one of the consulting oncologists who has also completed the voluntary assisted dying training. Both the coordinating practitioner, in this case Jenny's GP, and the consulting medical practitioner both satisfied that she meets all the eligibility criteria, and of course she has capacity to make decisions about proceeding with voluntary assisted dying. Each of the doctors submits their results of their assessments via the VAD portal, and it goes to the Voluntary Assisted Dying Review Board. Jenny is clear about wanting to proceed with this. She makes a decision, a written declaration in the presence of her GP and 2 witnesses, and at the same time makes her final request verbally. She appoints John as her contact person. Just remember, the contact person is merely responsible for arranging for return of any unused voluntary assisted dying medication to the central pharmacy. So the coordinating doctor sends all the documentation down the portal again, and the DHHS then via the portal will send back a patient administration permit. All this is done online via the secure VAD portal, which doctors who've done the training and have taken patients through this have access to. So once the permit's received, and maybe a few weeks down the track here, the GP contacts the statewide pharmacy service, and Jenny and discusses the prescription. Jenny and John contact the pharmacy to arrange the medication to be dispensed, and the medication is delivered to the home in the mandatory lockbox. The pharmacist gives detailed instructions about how to store and take the medication, if and when Jenny chooses, if and when. So Jenny's disease continues to progress over the next few weeks. She's thought a lot about who she wants to be with her when she dies and makes arrangements with her family. In their presence, Jenny takes the lethal dose of medication. She becomes sleepy and falls into a coma within 10 minutes and dies 25 minutes later. A very profound time and sad time for her family. But having said that, they were very supportive of her choice. John contacts the community palliative care service, as would happen usually when a patient dies at home, and they've been involved in Jenny's care right up until the time of death, even though they wouldn't necessarily be present at the time of her self-administration. They inform the nurse actually comes to the home soon after, as they often do, not always, but sometimes do, provides immediate support and assistance for John and the family, informs the coordinating medical practitioner of the death, arranges for the funeral director, and away we go under normal circumstances. As in all expected deaths, there's no absolute requirement for the doctor to attend the home to verify the death. Sometimes the GP or coordinating doctor may wish to do so, to in fact confirm the circumstances or to offer support to the family, but that's not necessary. The GP does the death certificate within 48 hours of death as usual, and the bereavement follow-up for John and the family occurs as per usual arrangements by Community Palliative Care Service, as it would for any other expected death. That's the end of the slideshow. I probably now perhaps turn my attention to some of the questions that Glenn has indicated here. Can I just say a couple of things firstly about this process? The patients that we've had in our health service and the feedback that we're getting from families is that the patients lose consciousness easily within 5 minutes. It's quite remarkable. And the deaths seem to occur within 10 to 15 minutes. Now, there's going to be variation in that, depending on circumstances and with the particular patients. But the feedback that I had, one patient actually came today, spoke to me. She was the contact person of a patient who died at home with voluntary assisted dying on Sunday. And she said the whole process was very peaceful and very, and it was a relief for the family to see that her suffering had ended. So I don't want to put rose-coloured glasses on that, except to say that our feedback so far, and there will be difficult circumstances, of course, but at this stage, death occurs quite quickly, and much more quickly than perhaps we'd expect from other oral medications. But this is quite a high dose of pentobarbital mixed up in a powdered form, and it clearly causes unconsciousness, peaceful unconsciousness and death within a relatively short period of time. The other thing that's important to point out is that people worry about bereavement for families, and the research from overseas clearly shows that patients with bereavement follow-up in these patients, the risk of bereavement and complicated bereavement and grief is actually reduced in this group of patients and their families. Of course, with the exception perhaps where families are in great dispute about the patient's choice, that also could cause issues around grief. But for the majority of patients, and certainly overseas jurisdictions, particularly in Canada where this research was done, patients who've accessed assisted dying, their families have actually much less complicated grief. They've been able to honour their patients, the family's wishes. They've seen their suffering end peacefully without having to struggle through those final weeks, days, and in fact have less complicated grief. So that's reassuring, but that doesn't mean all families will have that experience. So I think one of the questions was how the registrars, how can registrars raise advanced care plans, death and dying with their palliative care patients and keep within the law? I think I hark back to my earlier part of the talk is that I think open discussions about how things are going, what are your wishes should things deteriorate, let's hope for the best, but plan for the worst. Let's make some advanced care planning about this. And of course, there's a lot of information on advanced care planning on DHHS's website, end of life website. You can actually point patients to the DHHS end of life, not the VAD, but the end of life website, which has all sorts of options. The 3 options that are on that website, without specifically mentioning VAD to the patient will get information about advanced care planning, about palliative care, and about voluntary assisted dying. So the discussion can be had openly about patients' wishes without actually having to bring up voluntary assisted dying, unless the patient actually wishes to talk about that. So it shouldn't stop us from having open discussions about how things are going, how do you think you're travelling, how do you see your treatment going, what would happen if things didn't go as well as we'd expect. Let's get some ideas into an advanced care plan. And we know advanced care planning is poor in the uptake in our community. We need to encourage that, particularly with patients who are confronting advanced illnesses, whether they're getting towards end stage or not, but earlier the better, having these conversations. And patients will, in my experience, often bring up issues about voluntary assisted dying, or won't even mention it if that's not on their agenda. So they can be pointed to that, the voluntary assisted dying, the DHHS in Victoria website, which will have information about various aspects of end-of-life care. No, as a registrar, would not be entitled because of the, they need to be vocationally registered and they need to be a fellow. One of the 2 doctors has to be a fellow or vocationally registered for 5 years or more. So it's theoretically that a fellow could be, but not as a, unless the registrar is a fellow and is vocationally registered, they would not. They would then be in a position to either say, I discuss it with my supervisor, or if they're confident enough to say, look, I'm unable to assist you with this, but I can direct you towards information about that, either through the voluntary assisted dying care navigators or through the website. There are a number of things I hope I've covered. Yeah. Right. Yeah, that's right, and that's one of the reasons my old medical school colleague rang me today about was what are the funding issues. Well, certainly there's no specific funding for voluntary assisted dying activities, but a patient who comes in for a long consult would get charged a long consult. A patient who needs a home visit would get charged a home visit. Clearly, there are no item numbers if a doctor has to attend for a long period of time for discussion, but sometimes there might be an explanation to the patient that they may be charged privately if it's a long involvement. There's certainly no compensation for doing the 8 hours or 6 to 8 hours online training, that's for sure, as there are no compensation for other types of online training in general practice, I gather, these days, such as methadone prescribing or whatever. So you have to be keen to help someone. A lot of GPs have said to me, why should I bother? I might only see 1 patient a year. Fine, I understand that. I think it doesn't mean you should bury your head in the sand and not know anything about voluntary assisted dying. It'll be a personal choice. Some GPs have said to me, look, it's only when I've met 1 key patient that I've realised that this is important and that I will do this for this patient. So it's really a matter of a choice about that as to whether you are motivated or wish to go through the online training and then help patients in that circumstance. If not, then of course, referring the patient to someone, or particularly through the care navigators, because you're unlikely to know of anyone in your vicinity, perhaps, that is involved in voluntary assisted dying, but contacting the care navigators within our state anyway, and I presume hopefully that will happen in WA as well, will be a way of connecting people to the services and to further assistance. Well, as most people will know, Victoria is the only place that has current legislation in place. WA has passed their legislation recently. They will have an implementation period, which I can't exactly remember how long that will be, but we had an 18-month implementation period where this gives an opportunity for proper implementation of the law into actual healthcare practice. I know that now Queensland are starting their inquiry, end-of-life care choices inquiry, as South Australia. They're the two states that I know are going through the more formal process. And of course, there have been many attempts to get this legislation through parliaments, and many of them have failed. And that's particularly because they've been virtually private members' bills. This is the first time that an exhaustive process has occurred in a state process, and that happened again in WA. So other states are going through that, and they will come up and draft their own legislation, which of course then be debated in their state parliaments, and whether or not they will pass parliament will of course depend on a number of factors. So most states are very much looking at this. I don't know of any plans in New South Wales for this to occur at this stage. So I'm not completely sure. What is included in the VAD medication? I think I've said it's a high dose of pentobarbital. Of course, we access pentobarbital. The Alfred Hospital accesses pentobarbital, human use pentobarbital, not veterinary use pentobarbital from overseas, from a reliable source. The medication that's used in the doctor administered is a combination of drugs that are normally used in intensive care, such as midazolam, rocuronium, and the other one escapes me, for high sedation. I'm sorry, I just had a mental block. But they're just big doses of those drugs. So there's nothing special in the intravenous medication, but there's no doubt that the oral medication is high-dose pentobarbital. During the process of injecting the VAD drugs and the person becomes incapacitated to making the decision, can the medical power of attorney decide to stop the process of VAD and resuscitate the person? No, they can't. Once the patient has agreed and is witnessed to have made a decision, then the injection occurs and the patient, of course, they lose capacity, they become unconscious and they die. A simple matter of fact, and no one can prevent that. The patient has legally accessed, has been legally assessed. No one can intervene at that stage. If the contact person for voluntary assisted dying ends up using the voluntary assisted dying drugs or left over and dies or becomes severely ill, will the VAD coordinating doctor be held responsible? No, they won't. People often say, well, what happens if the person dies and then the loved one takes their voluntary assisted dying medication? Well, the short and trite answer to that is they die. Almost certainly they will die. And that's their decision. They've made an unfortunate decision to actually suicide. Now we've seen that happen prior to this legislation purely by patient dying and the spouse, loved one, taking excessive amounts of opioid, which are in the home or benzodiazepine, and dying as a result of that. I see this as no different. The experience of that is so rare in overseas jurisdictions as to be almost negligible, and I don't think that's a consideration. It certainly will have nothing to do with the coordinating doctor who has been through the proper legal processes and has found the patient eligible as well. What else is there, Glenn?
We have a question about the possibility of hearings recording again. We're absolutely recording it, so you will be sent this out.
Okay.
Lots of questions here about religious beliefs, conscious.
Yeah.
Really very nice. So,
okay.
there's a question here around choosing the correct decision. It's a question about essentially counselling the individual family.
Yeah. Yeah, look, that's a very good question, and I think this is one of the keys to this whole process. I've been involved in 3 patients, 2 of whom have completed. I actually had 3 months off last year on sabbatical, so I was out of the system for 3 months. So I've had 2 patients complete voluntary assisted dying by self-administration. I had another patient who died before she could access voluntary assisted dying. And I've had a number of other patients who, after I've had discussions with them, I've actually, in effect, talked them out of voluntary assisted dying by saying, look, these are the other options, and having the time to explain that these actual options are realistic and may actually help them improve their quality of life without having to consider voluntary assisted dying. So it really depends on the patient. Some patients are testing you out to find out what your attitudes are. And I've actually, as I said, a number of times had detailed discussions with patients and their families about the fact that there are a number of other options that they may not have considered. Despite the limitations of excellent palliative care, and we can't fix everyone's suffering by any stretch of the imagination. We can do a lot, but we can't do everything. But patients sometimes haven't thought about, oh, maybe some palliative radiotherapy for that terrible bone pain may be useful. And there are a number of patients where once you've discussed that, once you've put all the possibilities of medication changes or getting a proper, a good palliative care specialist opinion, patients then stop thinking about it and talk about living out the rest of their life and choosing to live the rest of their life without having to access voluntary assisted dying. So it's not all one-way traffic, and I certainly, I'm very careful not to accede to a patient as soon as they start mentioning it. But having said that, patients who come in and want to talk about voluntary assisted dying, by and large, in our experience, have thought about it, are clear about it, and very few of them, a lot of those patients, they've often been a controlling type people, want to be in control of their life, want to be in control of their death. Very few of those patients will change their opinion. We can do a lot for them in the meantime, but many of them will still want to go down that path. There are others who have not perhaps thought that through in as much detail, as much planning, who we can actually help without having to go down that path. So it's very important about getting a feel for where people are at, helping them address some of the other options that they've got that they may not have considered. I think there was one there about can the Department of Health and Human Services permit issuing group, so that's the Secretary of the Department of Health and Human Services, so-called, can they veto or question the coordinating consulting doctor? Look, if there's some disparities and inconsistencies in the assessment processes, the doctors will be contacted by through email to say we need clarification on this, and if a patient clearly doesn't meet the criteria, then it can be vetoed. The Voluntary Assisted Dying Review Board is not a policing body. It's to really monitor and record and report to Parliament, but they have powers of referral to either Victoria Police, the coroner, or to APRA if they see that there's inappropriate or illegal activity going on. It's very unlikely if you see the process. I can't explain it better than that. No different to any other medical records. This doesn't make any difference to how long you keep medical records. Whatever the statute is now, I can't recall. Is it? We would have medical records on our patients in the hospital for forever. But there's no different to any other patient. Thank you very much. I hope that's been helpful. There's a lot of stuff, and I wish you well.